Sleep and mental health are inseparable, bidirectional, relationship, each affects, other, profoundly, cannot treat, one without addressing, other, this is clinical reality, research reality. 90% of depressed people have sleep problems, insomnia, hypersomnia, fragmented sleep. These aren't just symptoms, they're maintaining factors for depression. Treating sleep improves depression significantly. Insomnia is risk factor for developing depression, not just symptom. People with chronic insomnia are 10 times more likely to develop depression than good sleepers. This is causal, not correlational. Treating insomnia reduces depression risk by half. This is powerful prevention strategy, simple, accessible, effective, yet often overlooked in mental health care. REM sleep is crucial for emotional processing. During REM, brain processes emotional experiences from day, integrates them, reduces emotional charge. This is why good sleep after trauma helps recovery. Sleep deprivation amplifies negative emotions, reduces positive ones. Amygdala becomes 60% more reactive after one night poor sleep. This is why everything feels worse when tired. Prefrontal cortex control over amygdala decreases with sleep, loss, less regulation of emotions, more reactive, more impulsive, poorer decisions, all from insufficient sleep. This mimics mental illness, anxiety, and insomnia. Also bidirectional. Anxiety makes falling asleep hard. Racing thoughts, hyperarousal, worry, poor sleep increases anxiety next day through reduced prefrontal control, vicious cycle. Cognitive behavioral therapy for insomnia, CBT-I, is most effective. Long-term treatment more effective than sleeping pills. Addresses thoughts, behaviors. Maintaining insomnia changes them systematically. CBT-I components include sleep restriction, paradoxically limiting time in bed to actual sleep time. This consolidates sleep, makes it more efficient, gradually extend as improves. Stimulus control is another component, bed only for sleep and sex. If can't sleep within 20 minutes, leave bedroom, return when sleepy. This strengthens association between bed and sleep. Sleep hygiene education is part of CBT-I, but not sufficient alone. Combined with cognitive restructuring and behavioral techniques becomes powerful intervention. Cognitive restructuring addresses worries about sleep, catastrophizing about consequences of poor sleep. These thoughts create anxiety that prevents sleep. Challenging them reduces anxiety, improves sleep. Medications for mental health often affect sleep. SSRIs can suppress REM initially, though improves over time. Benzodiazepines reduce deep sleep, fragment sleep, despite sedating. This is trade-off to consider. Medication may help mental health, but harm sleep architecture. Sometimes net benefit is positive, sometimes not. Individual assessment required. Sleep medications are problematic long-term. Benzodiazepines, Z drugs create dependency, tolerance, withdrawal. Rebound insomnia don't produce natural sleep architecture. CBT-I is better. First line treatment, natural supplements can help. Some people, magnesium, melatonin, theanine, glycine, these support sleep. Without dependence or side effects of prescription drugs, worth trying before medication. Exercise improves both sleep and mental health bidirectionally. Aerobic exercise reduces insomnia, improves sleep quality, also reduces depression, anxiety. Powerful intervention for both. Light exposure matters for sleep and mood. Morning light sets circadian rhythm, improves sleep, timing also improves mood. Seasonal affective disorder responds to light therapy, which also improves sleep. Evening light, especially blue light from screens, delays sleep, suppresses melatonin, worsens sleep. Quality this affects next day mood, cognitive function, mental health. Screen management is crucial. Alcohol disrupts both sleep and mental health. Despite being sedating, fragments sleep, suppresses REM, worsens depression, anxiety, long-term, should be avoided for both conditions. The integration of sleep and mental health treatment should be standard, not exception. Every mental health assessment should include sleep evaluation. Every sleep problem should screen for mental health. Treating both together produces better outcomes than treating either alone. This is evidence-based. This is clinical best practice. This should be how care is delivered always. The message is clear, cannot separate sleep from mental health. They're intertwined biologically, psychologically, clinically. Treating one requires addressing other. This is foundation of effective care. Prioritizing sleep is mental health care. Treating insomnia prevents, treats depression and anxiety. This is simple, accessible, effective intervention that works for millions. Use it